All right, so today we're going to talk about the basics of nuclear cardiology. So I'm going to take you on a whirlwind tour of from injecting an isotope to getting an image. And you might be surprised actually how much goes into making an image. I know you all look at these images, but in terms of what goes into it, it's kind of important because knowing what goes into creating an image actually gives you a better idea about what's wrong with the image. All right? So let's talk about it first. First of all, we're going to talk about different radiotracers. Obviously, there are alpha emitters, and there are beta emitters, and there are gamma emitters. Alpha emitters and beta emitters we don't image. And why is that? Because alpha emitters are stopped by tissue paper. Beta emitters are stopped by a piece of paper. And only gamma radiation gets outside the body. Okay? So if you inject someone with a radiotracer, you better hope it gets out if you're going to image it. Okay? And so alpha emitters and beta emitters we don't do. The other thing is that we don't really like alpha emitters because alpha emitters cause a lot of radiation damage, about 20-fold greater than what you get with beta and gamma, okay, in terms of their biological effects. So alpha is not something we really like. Alpha is great when you're giving therapeutics and you want to destroy tissue, but not very good for imaging. Huh? Yeah, that's right. If you want, that's right. If you like polonium, if you want to kill a Russian spy, there you go. That's the best way to do it. You know, go look it up. Alpha emitters. They're very hard to detect because you can't put a gamma, a Geiger on someone. They don't get outside the body. But if you want to kill somebody, alpha emitters are really good. Okay. So these are some of the basics of nuclear physics. First of all, there are different ways in which we get decay. We can get decay by beta emission, and that's usually in neutron-rich nuclei. So what happens is when you emit a beta particle, which is negatively charged from an atom, now you go from a positron-rich, from a neutron-rich to a positron-rich, right? Because you can convert a neutron to a positron. And you have to remember, this is atomic number. Atomic number is always the top bar here. It's the number of protons and neutrons. Atomic number is the number of protons, and that defines an element. So, for instance, molybdenum goes to technetium. It doesn't change the atomic mass, but it changes the atomic number. You actually gain a proton because you get rid of one neutron by beta emission. So this is how one way of having decay. Another is isomeric transition, which is really just a change from an unsteady state to a steady state. You have electron capture, where actually the nucleus captures a electron, and so you go from a proton-rich nucleus to now a neutron. And so you can see here that you've actually lost a proton. You go from 81 to 80, and you notice that the element changes from thallium here to mercury. So it's important to remember, the atomic mass and the atomic number and these different kinds of interactions that lead to decay. Now, again, we don't really look at beta emission. We don't really image beta emitters. We image gamma emitters. But these are some of the ways in which it's done. What are some of the ways in which particles interact? You can have, for instance, with beta and alpha emitters, you can have excitation. You can have ionization, or you can have Bremsstrahlung, okay? Now, excitation is when you increase an electron to a higher orbital, okay? Ionization is actually when you eject, you have enough energy to eject an inner shell electron, which then causes an outer shell electron to go to that lower shell. And that in that lower, going from a high energy outer shell to a lower energy inner shell, you give off energy. Okay, that's X-rays. That's what we call characteristic X-rays. Reason it's called characteristic is because it's characteristic for that change from a higher level to a lower level shell. And then we have this Bremsstrahlung, which is when a high energy particle goes near the nucleus and slows because it's going near the nucleus. And as it's slowing, to have conservation of mass and energy, you lose energy. And so that's given off. So as mass goes down and as energy goes down, you give off energy. As it slows down, velocity goes down, you give off energy. Now, interestingly enough, this is exactly ionization and Bremsstrahlung are what you get when you do CT imaging. Okay, that's the standard for CT. What you usually do with CT is you bombard a target with electrons, and you either get characteristic X-rays, which are, as we talked about up here, where you actually eject an electron, or you get Bremsstrahlung, where you actually get a loss of energy of an electron, which then is given off as energy. So with CT, we use this all the time. We don't do this in nuclear cardiology. Only in CT do you see these kind of things. In nuclear cardiology, we do something different. We do have photoelectric effect, and that's because of gamma rays. So if you eject a gamma ray, you can have a complete conversion of electromagnetic energy into kinetic energy, and this is done by ejecting what we call a photoelectron, and this is what we call a scintillation or light. It gives off a little bit of light, okay? And it's those light changes that are actually picked up by the camera in terms of being able to detect a photon being ejected. So photoelectric effect is a complete conversion, 100% conversion. Then we have other things where maybe an electron is deterred. You change the course as it's ejected. So you have a Compton photon and a Compton electron, and we commonly see what we call Compton scattering. Compton scattering, where a gamma ray hits a tissue and it causes a change in the configuration and the direction of something, but doesn't absorb all the energy. So this is something that we deal with a lot in nuclear cardiology, and it's a curse because it really can affect your spatial resolution and how well you do. And then we have high energy positron emission tomography, where we actually can develop pair production, and then we develop positrons, which are positively charged electrons, which then can interact with tissue and lead to annihilation, 511 kV energy, which is picked up by a detector. So this is in tissue and in crystals, and again, this is also in tissue, both of these other. Now, this is the photoelectric effect. So here a photon is absorbed by the atom and energy goes to a free electron, and that's what we were talking about earlier. This is Compton scattering. And Compton scattering, again, is where you eject an electron, but you eject it, it doesn't go in the same course, it goes at an angulation. And this angulation is important because the greater the angulation, the greater the loss of energy, okay? So if you scatter at a very shallow angulation, you won't lose a lot of energy. If you scatter at a very great angulation, that's where you lose most of the energy. The other important thing to remember is that high energy tracers like F-18 or technetium, for every degree of angulation, they lose a greater degree of energy than low energy tracers, okay? So that's important because we do not want to image scattered photons. Scattered photons cause a reduction in our spatial resolution, okay? So if we use something like thallium, okay, we can actually get 78 degrees of deflection of that photon, before it goes outside of our window of acceptance in terms of the energy degradation. Whereas with technetium, it's only 54 degrees, and look at with F-18, it's only 27 degrees. Okay, so anything above 27 degrees we're not going to detect. We're going to say it's outside our energy range. Okay, so this whole idea of Compton scattering is important, and this is the main problem that we have in tissue in terms of having scattered photons. So again, the greater the angle, the greater the energy lost, and the higher the energy of the tracer, the greater the energy lost per degree of angulation. Okay. Again, this is what we see with PET. PET, we're giving off positrons. Positrons interact with electrons after they go a certain distance, and they cause annihilation with 511 keV photons in 180 degree directions. Now this is also important because every PET tracer has its own intrinsic energy, okay? And so the higher the energy, the further that photon will go through tissue before it's annihilated. So you might imagine then that F-18, which has relatively low energy, will go a short distance before it is annihilated, whereas rubidium, because of its high energy, will go considerably farther. That's called its positron range before it's annihilated. What does that mean? That means that if an event, if an emission occurs here, but it goes all the way out to here before it's annihilated, look what happens to your spatial resolution. Okay, you degrade because you're not really imaging what happened here. You're imaging what happened out here. Okay, so PET agents with short positron ranges that have low energy give you better spatial resolution from a theoretical point of view than those that have higher energy. The other thing to keep in mind when you think about Compton scattering is that it's just not one thing. I mean, you can have multiple scattered events, okay? So it's like a ping pong ball going, through space. I mean, it can bump into this and then bump into another one and then bump into another one, and finally, you'll measure all of these until you go outside the energy window. Okay? So this is really bad because you can be out all over the place here in terms of where an event initially occurred and where you finally register it. And again, it's determined by how much energy is lost in terms of being within the energy window of the radiotracer. The other thing to keep in mind is that when you look at different structures like tissue or the sodium iodide crystal, which we use to image, or lead, most of what happens in tissue is Compton scattering. There is some photoelectric effect where you have absorption, but of the entire photon, but most of it is Compton scattering. In sodium iodide tissue, you have primarily photoelectric effect, and that's certainly true in lead. Remember, lead is going to absorb all that energy, right? And it's not going to get through. And it's important to remember that thallium, obviously, with its lowest energy, has the most likelihood of having just plain Compton scattering in tissue, okay? And it's also important to remember that tissue attenuation depends not only on photon energy, it also depends on the density of the material, okay, lead being the densest, right? And also the thickness of the material. So we talk about half value layers in terms of how thick does something have to be for half of the photons to not get through or to pass through. Okay, that's the 50% half value layer. Okay, so all of these things come into play when we think about being able to image and getting photons out of the body to get to the crystal head. And again, thallium and technetium both, their primary interaction in tissue is Compton scattering. So here we are. This is an example of a liver. We're doing a liver scan. We have this thing called a collimator, which helps direct the proper photons into the crystal. Then we have the scintillation crystal, which is going to, obviously, when the photons go in, it's going to cause that ionization or that photoelectric effect, that scintillation. And then that's going to be registered by a complex array of photomultiplier tubes in an X and Y direction, and then that's going to make a picture. Okay? And the most important thing about gamma cameras is actually the collimator, because the collimator is what allows photons from an X-ray source to actually hit the crystal. Okay? And so in a general nuclear cardiology study, 99.9% of emitted radiation never gets to the crystal. It's emitted, but it never gets to the crystal because it's stopped by the collimator. So you only get very selective amounts of radiation to hit the crystal. And so, but the collimator is incredibly important because you don't want photons from somewhere else that are scattered or whatever to get into your line of flight. You want photons that are here from the patient going directly to the camera so that you get and accurate representation of the patient's organ that's being imaged. And again, the collimators are very important, and the collimators, in terms of the ability to improve spatial resolution or what we call sensitivity, the amount of counts or photons that actually get to the crystal surface, is determined by the length and width of the holes. So that brings up another very important point.
How thick?
I'm sorry?
How thick is the collimator?
Well, they vary. And I'll show you. They're millimeters in terms of thickness, okay? But I'll show you different types of collimators, because some have thicker, some are wider, some are longer, and that depends on what your spatial resolution will be. This is an incredibly important figure. This is the full width half maximum. The full width half maximum is what a point source would look. So if I were to image just a dot, it would look like this Gaussian distribution, okay? And how wide that little dot would be would depend on the full width half maximum. So if you had a little dot here, you would expect it actually, depending on your gamma camera, to be about this wide, okay? That would be one dot. So the question is, how do you distinguish one dot from another dot? How do you do that? Well, the only way are for the dots to be separated greater than the full width half maximum. Okay? So that's an extremely important concept in nuclear cardiology. So here's an example. These are this is a point source here. This is a point source here. Here's the full width half maximum. Okay? Well, you can see that the full width half maximum is actually greater than the separation, the distance between those 2 points. So in this example, you would be able to distinguish 2 separate points. Okay? However, in this example, you have a point source here and a point source right here. Okay? And now the full width half maximum exceeds the distance between the 2 points. So now those 2 points are not going to be distinguishable. They're just going to be a blob. One big blob, okay? So the spatial resolution of any system is going to be determined by the full width half maximum, okay? And the spatial resolution of any gamma camera is going to be based on the intrinsic resolution of the system without the collimator plus the collimator. And the collimator actually has the most influence on what the full width half maximum will be. So let's talk a little bit about sensitivity and resolution and collimators. So as I said, collimator resolution is determined by the diameter and length of the collimator holes and the distance of this object from the collimator face. Very, very important. Collimator sensitivity is also determined by those factors. It's not determined by how far the collimator is from the surface of the crystal, okay? How far the organ is from the surface of the crystal. But as you make the holes bigger and as you make the holes shorter, your sensitivity will increase, which is the amount of counts that actually, or the amount of photons that actually hit the surface of the crystal, okay? So here's a nice little summary of this. If you increase hole diameter, okay, you're going to decrease resolution, but you're going to increase sensitivity. If you increase hole length, you're going to increase resolution, but you're going to decrease sensitivity, okay? So there's always a trade-off in terms of what kind of collimators you use in terms of being able to improve spatial resolution, but by the same token, not have to image someone all day long to get a picture. Because remember, sensitivity is the number of counts that you acquire. So you have to have counts to make an image, right? So it's very important to have sensitivity, but you also want to preserve spatial resolution. It turns out that different collimators for any amount of spatial resolution will have different sensitivity. So notice that sensitivity and counts are inversely proportional. So as sensitivity increases, then resolution decreases. Okay? And so these are very high, ultra high resolution collimators where the sensitivity is going to be very low, but the spatial resolution is going to be high. We usually use in between, we usually use a high resolution collimator where it's a little bit of an offset where we get reasonable collimator resolution and still adequate counts. The other important point, as I said, is the distance away from the face of the camera a patient may be if you're going to image the heart in terms of the distance from the camera. So here's an example of a full width half maximum. Look at where this point source is or where this heart would be in terms of what photons are going to be. So this is the Gaussian distribution here. Now look what happens when we move the patient further away from the head of the gamma camera. Look at what happens to the full width half maximum. It gets that much wider, okay? That means your spatial resolution is being degraded, okay? And notice that when we go from one low energy collimator to a high energy collimator, even though this point source is still far away, now we get, look what happens to the full width half maximum. Because the septi are longer, okay, so less get in, so it's more directed. So you can see the effect of full width half maximum on patient positioning and what kind of collimation that you use to image the patient. Now, we always try to get, when we do imaging, we try to contour the camera as close to the chest wall as possible, okay, because that improves not our sensitivity, it's a misnomer in terms of how many extra counts you're going to get having the camera closer to the patient. What you improve is your spatial resolution, okay? And remember that the spatial resolution for deep structures in the chest, like the inferior wall of the heart, is going to be the worst because that structure is furthest from the collimator, whereas the anterior wall is going to be closest to the collimator, so you're going to get much better spatial resolution in the anterior part of the chest than you are in the posterior part of the chest. And there are techniques that we can use to improve what we call resolution recovery. There are techniques that can be done to help compensate for that difference in depth of the chest in terms of spatial resolution. But it's something from a physics point of view, as long as you have a collimator, this is what's going to happen if the patient is closer or further from the camera head, and depending on what your type of collimator is. Okay?
So from something that you can adjust, right? I mean, you have to decide on your collimator, the physics of the machine.
Right.
There are two things, at least to my knowledge, that could influence your sensitivity and your spatial accuracy. Is one, the type of agent you're using, and two, how close are you to this camera? Is there something else?
Right, so being close to the camera doesn't affect your sensitivity, but it does affect your spatial resolution.
Right.
In terms of improving counts, that's going to be due to the material, the crystal that you're using. So for instance, CZT, you get much higher count rates with CZT than you do with sodium iodide, for instance, okay? And so the type of material you have, and also when you look at thallium, for instance, because of the tremendous amount of Compton scattering you get with thallium, a lot of those photons never get outside the body, okay? So with technetium, you're more likely to get a higher sensitivity for any degree of millicuries than you are with thallium. So it depends on, it depends on the radiotracer, and it depends on the system itself. Okay. Again, this is again the issue that the further you move away, the worse your spatial resolution. Again, going back to the issue of the full width half. Now, this is the same collimator. Here the collimator is very close to the patient. Here it's further away, and you can see what happens to your full width half maximum. So it's very important to get the patient as close as you can to the gamma camera. Okay, and again, it does depend a little bit in terms of what kind of camera you use. So this is a general purpose collimator, this is a high resolution collimator, and this is resolution. You can see that loss of resolution is greater with general purpose collimators, and that has to do with the septi and the thickness of the septi and the length as compared to high resolution collimators, but still, irrespective, as you move further and further away, your spatial resolution degrades. Okay. So let's move on. So now we're up to we got the photons into the gamma camera. Now we're going to start looking at the crystal, right? So the whole idea is that we have a scintillation material, the sodium iodide crystal. Then we have a light detector. These are photomultiplier tubes. And then we have to have a voltage discriminator in terms of what energy we're actually looking at, and then we have the display. So there is a certain thickness of sodium iodide crystal which is best. You might think of it this way. There's an ideal thickness for everything. Depending on the energy of the photon, okay, and we see this in CT also, if you have a very high energy photon, it's going to pass right through the crystal. It's going to go through the crystal, and it's never going to be imaged, okay? And so we see that in CT. If you use, for instance, 140, 150 kV photons or kV electrons in CT, you get a blackened image because you don't attenuate anything, right? Everything just passes through. So you want to make sure that you have a proper thickness of crystal where you can maximize your photoelectric effect, but where you also can maximize the number of photons that are actually going to undergo photoelectric effect, which is going to be due to the thickness of your crystal. Okay, so that's an important first concept. The other important concept is energy resolution. And you actually have improved, your full width half maximum for energy resolution is better with technetium than it is with thallium. And you can see as energy increases here, the full width half maximum goes down. So technetium is 140 kV, thallium is only 72 kV. And so when you're trying to discriminate energy, remember we have all these Compton scattered events occurring, and you want to discriminate just a certain energy peak that you want to image, you're going to do better with technetium than you are going to do with thallium, which is one of the reasons why we really don't use thallium imaging anymore. The only positive for thallium is that its extraction across blood flows is pretty linear compared to technetium agents. But as far as all these other physical properties of thallium, it's really a suboptimal agent. So we have to be able to look at what kind of energy is going through. So we have a way of discriminating voltages. So these are all separate events that happened in the crystal, okay? And we want to be able to look at 140 kV plus or minus 20%, okay? So in other words, in these kind of situations, this would be the energy window. These would be outside the energy window. These peaks would be inside the energy window. Those are the ones we want to be able to image. And so when we do a energy peaking and we look at the energy, we want to be able to say this is the 140 kV photon of technetium, and we're willing to accept a 20% window, 10% on each side. So it can go down to 130 or go up to 150. We'll take either one, but it has to be within a certain range for us to accept that. And why is that? Because we already said if you degrade too much due to Compton scattering, you're going to degrade your spatial resolution tremendously. So you want to be within a certain range of energy that is the true energy of the radiotracer. So there's all kinds of different scatters that can happen in terms of, look at, this is Compton scattering, this is one event, this is two events. So there are multiple different scatters that can happen within the patient. And that's why we have to make sure that we don't want, first order, second order, third order, fourth order Compton scattered events. We want to deal only with the ones that come through and hit the collimator and have the proper energy where we can say not only has the collimator decided that this event is linear with the patient and that's the proper photon, but the energy has also determined that this is not a Compton scattered photon that somehow just managed to get through, okay? Because it's the proper energy, and if it had been Compton scattered, you would have not been able to accept it. You would not accept it, okay? So there are ways in which, through the geometry of the collimation and through the energy of the radiotracer that we're using, that we can identify properly image the organ. And again, this improves our spatial resolution. The other thing I want to say is that we now have CCT cameras, and the CCT cameras actually have better energy resolution than what we see even with sodium iodide crystals, okay? And so what does that mean? Again, that says that spatial resolution, because of enhanced energy resolution, will be possible. We'll have less Compton scattered events that will actually register and be able to say, yes, this is a real event, not a Compton scattered event. The other thing, there are certain other ways in which the instrumentation changes things. So in different parts of the crystal, you have different photopeaks occurring at different places. One of the things that happens when you use this with energy corrections, you align the photopeak so everything is in the same row and not scattered. And with energy correction, you can see that from here to here, that you get more precise spatial resolution than you do without energy correction. Okay? The other important issue that we talk about is gamma camera uniformity. Now, uniformity is important because the surface of a crystal is not uniform. In other words, how a certain part of a crystal interacts with a photon will be different in different parts of the crystal. It's not 100% uniform. And we need to know where those non-uniformities occur in order to get an even image, right? Otherwise, there would be a lot of variation in the image, okay? So uniformity becomes incredibly perfect, and we're able to actually look at uniformity and actually correct for areas of non-uniformity with the crystal. So there are certain things that we look at. We look at integral uniformity. This looks over the whole area of the crystal. It's a 1,000-foot, 10,000-foot view of the crystal, okay? And then we also have, just to go on, this is divided into two different usual field of view and central field of view. And so this is integral uniformity. So this is looking at all across the crystal. And in this situation, you can see the integral uniformity is about 4 to 5%, which is acceptable. Notice this, over 5% is not considered acceptable uniformity. This crystal is terrible. Look at how blotchy this is. This is 10 and 12% uniformity, okay? So there's something definitely wrong here. I mean, this is very bad. We like to be within 3%, but no more than 5% non-uniformity, okay? And this is looking at the whole crystal. Now, this is how we look. Now, there's something else called differential uniformity, which looks at a small neighborhood of pixels. So we have integral, which is over the whole crystal, and we have differential, which is over a small area. We do both. We do both. So for instance, with integral uniformity, we would take the highest here and the lowest here and subtract them and divide by the two of them together, and we'd be able to get the integral uniformity. With differential uniformity, it's done over 5 pixels in each direction, 5 pixels in the x-axis, 5 pixels in the y-axis. So that's a small neighborhood, okay? So within each small neighborhood we would look. So here you would see that 2270 is the hottest pixel, 2100 is the least pixel along those 5 pixel averages, and now when you do the equation, you get 3.9%, okay? So we look at both. We look at both overall uniformity, and we look at differential small area of interest uniformity, and then what we do is we take all of that information and we correct every day we correct for uniformity on our cameras before we start imaging, okay? We have a correction map, okay? So very, very important. Okay, how do we do intrinsic measurements? Well, these are usually done with point sources, and we go 5 usual field of views from the detector surface. You put a point source out there. This is without the collimator, okay? This is with the collimator. We do these routinely all day long. So we usually use cobalt sheet sources, where you just put a sheet source on the camera top, okay? Why do we use cobalt? Because it's very close to the kV of technetium, which is 140 kV. And this is nice because this is with the collimator, and we just put the cobalt source on there and we take a picture. And we get a uniformity map. And we do that every single day before we do imaging to make sure that the maps can be corrected for each camera we use. Okay? There are ways in which these are the various causes of non-uniformity. You can have crystal damage, you can have PM tube failure, improper coupling of the PM tube to the crystal, incorrect application of correction maps, incorrect energy windows. There's a whole slurry of things that can happen. But this is why we need to do uniformity on a daily basis to be able to look at these particular issues and make sure they don't occur. Okay, so that's gamma camera uniformity. Now spatial resolution. Now it turns out that spatial resolution and non-linearity are important concepts also within nuclear cardiology. So it turns out that most of our, except for the CCT cameras, which don't have PM tubes, they don't have PM tubes anymore, but all the other typical gamma cameras have PM tubes, okay? A PM tube has a nonlinear response to light across the face of the tube. So it turns out that if light comes in here, that there's a greater output signal toward the periphery of the PM tube as compared to the center of the PM tube. And so this consequently moves events near the edge of the tube to the center, okay? So that can cause a picture like this. Well, how are we going to read that? That's terrible. All you got these are all individual PM tubes, okay? So that's not going to work. So we have to do linearity correction on these in terms of making everything even, and look how much better the flood correction looks, okay? So this is something that's very important with PM tubes. Like I said, with CCT cameras, we don't have to worry about this because you don't have PM tubes. But with the traditional angle cameras, this is something we need to do. We also look at linearity in terms of bar phantom. So what we do here is we put a bar phantom on the camera head, and we have a point source, and we look at how well we can discriminate these bars. Okay, so we want to be able to discriminate the least distance between these bars. So this would be terrible resolution. This would be better. This would be better still. This would be the best if you could discriminate between those bars. And it turns out that using a bar phantom, the spatial resolution is determined by about 1.7 times the smallest bar size C. So the full width half maximum is going to be about 1.7 times the smallest bar. So we do these also routinely, and we rotate these bar phantoms about 25%, okay? So four different rotations every time we do these to look at different parts of the crystal in different bars. So these are something we do to look at spatial resolution. Then we have, the last thing we have is center rotation. Center rotation, remember these gamma cameras rotate around. Now there are certain fixed gamma camera gantries. For instance, GE had a CCT camera with pinhole collimator, which was a fixed gantry. But most gamma cameras go around the patient 180 degrees opposite each other. And if they're not aligned properly, you'll get a misalignment of the image. So this is just looking at different problems with center of rotation error. This is if you're off 1.5 pixel. This is if you're off no pixels. And this is you're off plus 1.5 pixel. You can see you can cause false defects because the back projection that is done is not done properly. Okay? So we always do center of rotation so that we ensure that everything is the same going around the patient, okay, in terms of the back projection technique. Getting then into back projection, once we acquire all these data, we have to make an image. We have to reconstruct it. How do we reconstruct it? Well, you know, if I were looking at Dr. Nabi, if I go over here, I see a little different picture of Dr. Nabi. If I go over here, I get still a little different picture of Dr. Nabi, okay?
Which one is best?
Well, yeah, which is best? You know, I get all different pictures. So that's the same thing when we do with the gamma camera. When it's rotating around, we get a picture of Dr. Nabi from one angle, and then we bring it around, we get another picture from Dr. Nabi on another angle, and then we triangulate all these things to make an image. So you can imagine that if you just had one picture of Dr. Nabi, this is all you'd see. You wouldn't see anything, okay? But if you had two pictures, now you're starting to see a little bit of a profile. At 4, now we're starting to, gee whiz, now there's all these intersection of points. And finally, when we have a whole lot of intersection, remember we have 64 individual stops on these, 32 stops on each head, 64 total separate images every 4 degrees, around 360 degrees, 180 degrees, to look at Dr. Nabi, okay? And that's how we would get, if we had a picture of him, we would see a beautiful three-dimensional view of him by using filtered back projection. Incidentally, filtered back projection is not only used in nuclear, it is the way we get a three-dimensional picture when we do CT. CT and nuclear are actually, that's why we have nuclear and CT together. Because CT and nuclear are very, very similar in terms of acquisition, except with nuclear, it's emission of radiotracer, and we're collecting that. With CT, it's transmission of photons or X-rays into the patient, and with attenuation. But it's still attenuation, and you still use filtered back projection. We use iterative reconstruction. And actually, when we think about KV in nuclear is very analogous to KV in CT. And when we think of counts in nuclear in terms of being able to see an image, we say the best image is with the most counts. Well, it's also true that the best image in CT is with the most MA. And MA is equivalent then to counts. Okay? So the basics of filtering, this is extremely important. How much do you filter out noise? How much do you do that? Well, here's a nice picture. So this is an original picture. And now we're removing some high frequencies. And now we're removing some more high frequencies. And now we're removing all but the low frequencies. Well, you can see you have no picture. You take out the high frequencies and the medium frequencies, you have nothing but a blob. Okay? You would never know that this is this, right? So we want to have some kind of balance in terms of how much we keep and how much we get rid of. Okay? It turns out that frequencies, high frequency events are edges. Okay? So we want to be able to determine edges, and we want to be able to determine also the edges of defects in the heart, right? When we're imaging the heart. So we filter. The other thing you have to remember is that resolution is also always limited by pixel size. Okay? I don't care how much high frequency you take out or low frequency, if your pixels are big, okay, it's going to look blotchy. The smaller the pixel size, the better the image resolution. The image resolution. It has nothing to do with spatial resolution, it has to do with the image resolution. Okay? Spatial resolution is determined by the collimators and the intrinsic resolution of the camera. Okay? So again, how much do you filter? I tell you, when Mario Verani and I started with SPEC 30 years ago, I mean, you have no idea how we fiddled around with frequencies in order to determine what would be the best cutoff in terms of high frequencies and low frequencies. Okay? This is just an example. This is just an unfiltered back projection. Look how granular that is. That's with all frequencies, okay? Now we're changing the filtering. We're taking out some of the high frequency, now some of the medium. So this might not be too bad, but now look, if you take out all but the low frequencies, you get just this blob, okay? Blobs are no good. You wouldn't be able to pick up defects, right? So you don't like this because you might pick up a lot of defects that don't exist, all right? A lot of false positives, but you also don't want this because you lose distinction of defects. The other important thing is counts. Counts affects how much noise you have. Okay, so it turns out that noise is actually 1 over the square root of the number of counts. So if you have 100 counts, okay, you're going to get 10% noise. But if you have 10,000 counts, you're only going to get 1% noise, right? So we want to minimize noise. So the more counts we have, the better we do in terms of the image itself, okay? This is also true with CT. With CT, we try to really push MA so that we have less noisy images. The fellows who have done CT, they know what a noisy image looks like. It's terrible. Where's the stenosis? I don't know. There's too much noise. Okay? So you want to have MA, right? Or you want to have counts. Without counts, you have no image. You just have a lot of noise, and it's uninterpretable. Okay? And this is, again, this is something that Dr. Zaghi brought up. Higher KV photons. For any given amount of TOS and DIME, there's less tissue absorption in the body, so more gets out. Okay? And you have less Compton scattering. Okay? So this is very important in terms of having better spatial resolution, but also in terms of improving your sensitivity, number of counts that you actually image, right? It's good. Okay. After we do all this, now we also, in the last few minutes, I'm just going to talk a little bit about what we do post-processing. Now we've looked at everything, we've reconstructed. We should always look at raw data because we want to look at motion. We want to look at if there's any infiltration or extracardiac gut activity or contamination, etc., and attenuation patterns, right? So this is just an example of look how degraded this image is up here. You'd think there was an anterior defect here, and there really isn't. This is with motion, and this is with motion correction. Okay? And always remember that an artifact can hide or create a lesion, and of course it affects our diagnostic accuracy. I always say to the techs, even though we have motion correction software, it works fairly well for y-axis motion. It doesn't at all work for x-axis motion or circumferential motion. Okay? So if you have motion, rather than applying software techniques to get rid of it, the best thing is to reimage the patient without motion. Okay? Otherwise, you're going to have, Dr. Nabi is going to be very upset looking at the scan. He's going to say, why didn't you reimage this patient? Right? Okay, this is example of x-axis motion. I think you can see here that there's a defect in the lateral wall here. And this is now after the patient is reimaged. And now look, it's totally normal. So you might have called a lateral defect here in terms of a circumflex stenosis or whatever. It would have been bogus. Okay, so it's very important to recognize motion. The only way you recognize motion is to look at the raw data. I always say to all the fellows, the first thing you do whenever you look at a scan, you look at the raw data. What's the second thing you do? You look at the raw data. And it's absolutely incredibly important to always look at your raw image data. Also, with raw image data, you can look for attenuation artifacts. Obviously, breast attenuation is something we deal with quite frequently. And this is an example of variable breast attenuation where the breast was positioned different on the stress and the rest images. So here it looks like you got an anterior defect that actually normalizes, like there's ischemia. There's no ischemia here. It's just that in the rest images, you have the whole breast covering the whole heart. And in the stress images, only half the breast is covering the heart. So you get a false positive result. Okay? This is an example also. Here's someone where the breast positioning was bad, anterior defect, goes away with rest, bipolar maps, ischemia in the anterior wall. No, not so. In fact, this patient went for a CT because of this and had completely normal coronary arteries. Okay? Very important to really be careful about breast positioning. Also, diaphragmatic attenuation, more common in male patients, more common in obese patients, usually involves the inferior wall. You can see this here, this reduction in counts in the inferior wall. This is kind of classic attenuation. Nowadays, what we do is we do prone imaging. And here's an example where someone had an inferior defect on supine imaging. We brought them back, we did prone, they put them on their belly, did prone imaging, completely went away. Okay? So one of the things we use nowadays to help us do this, we can use CT correction, which we use, and we also use prone imaging to alleviate perfusion defects. And that's also true for anterior perfusion defects as well as inferior perfusion defects. We also have, obviously, problems with liver, stomach, and bowel, which can contribute counts to, let's say, the inferior wall and make a defect go away, or it can do the opposite. It can cause what we call a ramp filter artifact, which can actually lead to a false perfusion defect, Or it can actually you can actually have gut going over the entire inferior wall of the heart, for instance, where you can't even evaluate it. So there's a lot of reasons why we try to avoid liver, gut, and bowel uptake. Here's just an example. I mean, you can't read this scan. There's all this gut uptake over the inferior wall. There might be a defect there. There may not be a defect there. You're getting all these Compton scattered photons into the inferior wall from the gut. So someone like this should be really re-imaged, okay? And again, the RAM filter artifact is when you have adjacent hot count activity to the wall of the heart. This is an example of a patient where the gut was obviously next to the heart. And this is now a second stress image that was performed, giving the patient fluids and getting rid of the gut uptake. And now look, the defect is entirely gone. You can also get away with RAM filter artifacts by using iterative reconstruction, which actually doesn't use the RAM filter. So by using iterative reconstruction techniques, you can avoid a RAM filter artifact because you don't use the RAM filter, even though you still do back projection. So that kind of gives you an idea, at least in terms of image acquisition, all the things that go into actually creating an image. And every time you look at an image, these things should be going through your mind. You know, what could be causing this defect? Because I've always, whenever I read an image, I always assume everyone's normal. I assume everyone's normal, and then I look, prove to me, I have to prove to myself that that image is abnormal. Okay? And I do that by excluding all of these different things, all of these potential artifacts and misregistrations that could have occurred during the imaging process that could alter my accurate diagnosis. So that's just the beginning. That's just getting the image. We haven't talked about stressors, isotopes, clinical applications, all of these things. But this gives you an idea about how you get an image from a nuclear cardiac study. Thanks very much.
Thank you, John. John, just a quick question. Can we have the microphone? So correct me.
I can't move too far.
So correct me if I interpreted it incorrectly, what you said, but that the spatial resolution is going to be a function of how close it is to the crystal, right?
Well, it's determined by several things. Depending on the crystal itself.
Right.
The collimator is probably the most important factor. Okay? And then how far the patient is.
Right. So I mean, the other two things are uniform. In other words, they don't change from one location,
well,
one part of the heart to another.
That's true.
So the question, though, is what's the variability in the resolution between, let's say, an anterior wall versus a posterior wall, right? For that distance.
Well, you're talking, I mean, the spatial resolution, the intrinsic spatial resolution of a sodium iodide crystal is about 4 millimeters, okay? So with the collimator on, it's like 7 or 8, sometimes 9, depending on what you're using. And so it can still shift by several millimeters from anterior to posterior. Okay? So that does make a difference. But we have algorithms now. It's called resolution recovery. And don't ask me about the mathematics, okay? But there's actually a way to correct for that loss of resolution from the more anterior structures of the heart to the more posterior structures of the heart. Yeah. But in any event, from a clinical perspective, you should always have the patient as close to the gamma camera as possible. And I might add that resolution recovery, which is just one technique, they're all already in iterative reconstruction techniques. So if you use iterative reconstruction, it's already kind of within all of the different software packages.
Question for you here. John, this is a very nice overview of what goes behind the scene and what you need to do. I think this is very important. Question to you, one is, so since it is multi-modality imaging at the same time, so the highest resolution we have currently is CT?
For CT?
No, highest resolution from all of our imaging modalities.
It's like 0.5 millimeter, 0.5, 0.6.
CT, echo, MR than nuke.
Yeah.
Is the resolution better within the nuke, PET versus SPECT?
Yes.
Better
Yes.
resolution, I presume,
Yes.
with
Better.
PET that is coming shortly.
Better.
The other question to you is, although you're imaging patients prone and you're doing some CT attenuation correction, we still see from a clinical end a lot of disclaimer. And the disclaimer is an inferior wall attenuation at the base,
Right.
could be because of attenuation, et cetera, et cetera. But I see this much more frequently than in the early days.
Right.
So I would implore you to, with all the new technology now that you have, to decrease this, because then it throws an issue
So I'll tell you,
in the clinical portion.
Yeah, oh, I actually have this already. I don't need that. What we typically do on our reports, and I know, probably Faisal and everyone else reads the same way, but, if I say something is normal, it's normal. And I will say, but I do want physicians to know that there was attenuation in the walls, just so they know that. But the only time, if in the conclusion,
But it's coming too frequently at this stage of the game.
yeah, because we have a lot of attenuation artifacts. Yeah,
No, I mean,
yeah,
this is no resurrection over the years. No, what I'm saying is that now that you have even further technology
Yeah.
to try to improve your interpretation,
Yeah.
because I can tell you from an echo point of view, the inferior wall is always an issue. From a contraction point of view,
Yeah, sure.
and you have to kind of figure it in your mind and make a decision
Yeah.
one way or another. It is normal, yes or no.
yeah,
But what I implore you, because it is too much at this stage of the game, and with technology of prone imaging, CT correction, that you could decrease that nomenclature or that disclaimer, if you will.
yeah. Because
It's almost like routine nowadays.
Yeah, and maybe that is a little bit of a sticking point, because when I say something is normal, I mean it's normal. The only time I'll ever say that it's maybe not normal, I'll say probably normal. But if I say it's normal, I mean it's normal. So it just depends on. But I can understand if you see a disclaimer that, yeah. And what we do now is we say there's an inferior defect that normalizes with CT and prone imaging, which is another disclaimer of saying, look, yeah, this was an artifact, but in fact, what we can actually do, we can say there's an inferior attenuation artifact, and that way it says it's an artifact. You just say, instead of saying there's a reduction in the inferior wall, we can just say there's an inferior wall attenuation artifact which normalizes with prone imaging or whatever.
Whichever way.
Yeah. Any other questions? Okay, now you all know how to take an image, what to look for. Okay.